We have to be able to get the gene to the right location. We have to get that gene incorporated so that it will become, let's call it, active and be able to produce the protein that is needed to fulfill the function of what that person is missing.
Hi, I'm Ron Clayman, and this is Generation Hope. In this interview, I'm honored to be joined by Dr. Curtis Rogers, a senior clinical geneticist at the Greenwood Genetic Center, and a longtime leader in the Phelan-McDermid community who has been there from the very beginning. In this wide-ranging conversation, we talk about what inspired him to pursue medicine, how Phelan-McDermid syndrome was first recognized, and how families built a community even before the internet. We also explore how genetic testing evolved from early chromosome studies to today's sequencing, why access and insurance can slow diagnosis, the promise and ethical complexity of newborn screening, where AI is beginning to help in genetics, and the real-world challenges of delivering gene therapies to the brain. If conversations like this are helpful, please subscribe, like, and share. It's the best way to help support Generation Hope. And now, Dr. Curtis Rogers.
Okay, well, thank you very much.
No problem. I'm glad to be here.
There's so many exciting things that are happening.
That's
But let's find out about Curtis Rogers. Go back. What was the first memory you have of wanting to get into medicine and science and research?
I guess because I had a younger sister who died tragically of asthma.
Oh, wow.
And because of that, I felt like I wanted to get into medicine. I will say I was also shaped by the fact that I had an excellent pediatrician when I was a child. And that combined with my family's natural tendency for education, because it wasn't a question where you were going to college. I mean, if you were going to college, it was where you're going to college. Yeah. And I also have all four of my grandparents have at least a college degree, which is unheard of for somebody who's 71,
right,
like me, from a small southern town. So education was important in my family. I majored in chemical engineering in undergraduate school, even though I knew I wanted to go to medical school. I did that because if I got into medical school and I didn't like it, I'd have a job to fall back on. And if I didn't get in, I'd still have a job.
Uh-huh.
And as it worked out, I didn't get in the first year I applied, and that was fine. God works in mysterious ways, and I made enough money and saved and scrimped to pay for 2 years of tuition in medical school just from that 15 months of working as an engineer. So,
falling back on as an engineer.
Well, yeah. And then after that, I'd always known I wanted to do something in pediatrics, and I decided at that point to follow through on that in medical school and did a pediatric residency for 3 years. Then, again, the good Lord intervened, and I was going to do pediatric endocrinology and basically got invited to do a genetics fellowship. And the rest is history, as they say. I went on to do a fellowship at the Greenwood Genetic Center, which is a large, not-for-profit, non-university affiliated genetic center in South Carolina. And after my 2-year fellowship, I stayed on at the genetic center and was at the genetic center for a total of 40 years.
Wow.
So a lot of patients seen, a lot of articles written, a lot of meetings attended. As far as how I got into PMS, and we'll talk about this on Friday, but what happened was we happened to have a child in Greenwood, South Carolina, where I was living at that time. And this young man presented with significant developmental delays as a toddler. And we did chromosome testing on him and saw that he had a deletion of 22q13 at the bottom of one of his number 22 chromosomes. At that time, Dr. Phelan also worked at the Greenwood Genetic Center. Mm-hmm. And so Katie and I and a couple of other people were following this young man. And finally, we printed a paper in 1992 that was really the first description of a child with a 22q13 deletion, mm-hmm. thoroughly describing his features. We then started getting contacted by other families. And Phelan was contact point. So parents would call Katie and say, hey, I've got a child who has the same deletion of 22q13. Mm-hmm. And it snowballed from there on. And pretty soon, there were 20, 30 families.
Wow.
This was before
the internet.
This was all by telephone.
Yeah.
And things snowballed. And in 1998, the Greenwood Genetic Center in Greenville, South Carolina, hosted the first Phelan-McDermid syndrome meeting for families. And every 2 years since that time, we've had a family/scientific meeting, and it provides an opportunity for families to meet each other, mm-hmm. know they're not alone, that there are other children out there that have the same problems that their children do. They can provide support to each other, but also education to each other on mm-hmm. how to deal with the school system, how to deal with doctors, how to deal with different types of medical problems, such as seizures or gastrointestinal problems. So they grew and grew as, I'll say, the PMS family. Mm-hmm. And as that family grew, it got larger and larger. The mm-hmm. meetings kept getting larger and larger. And ultimately, it wasn't just in the United States. Mm-hmm. It was Germany and Spain and Australia and South America and many different places started hosting family meetings. Mm-hmm. We also provide a scientific component to the meeting where, for the family's sake, is geared toward the families. We discuss gastrointestinal issues, mm-hmm. seizures, developmental issues, augmentative communication, even things that are not medical, like how do you set up a special needs trust right. for your child that will be there in perpetuity mm-hmm. for their care. Unfortunately, none of us are going to live forever. Yeah. And I think a parent's utmost fear is what's going to happen to my child
when we're gone.
When I'm gone.
Yeah, absolutely. It's the hardest thing to think about.
Yes.
Yeah.
Even if you have a child that has typical development.
Sure.
You worry about that. If you have a child who's dependent upon you for care, that becomes a life-consuming issue.
Yeah. When you and Katie first started hearing from families, how were they diagnosed? I mean, were they diagnosed through...
They were diagnosed mainly on chromosome analysis because we Didn't really have microarrays back then, which has allowed us to make many more diagnoses. But on the chromosome analysis, looking at slides under a microscope, which is Katie's forte, that's how the diagnoses were made. And you have to realize to see a missing portion at the bottom of chromosome 22 on a good karyotype or chromosome study, you're going to have to be missing 5 to 10 megabases of DNA,
large,
which is 5 to 10 million pieces of DNA.
Yeah. And mutations wouldn't show up there. That would just be deletion.
Mutations would not show up. Now later, progression to microarrays, where we were able to start looking for smaller and smaller deletions, helped us make many more diagnoses. And at the same time, we were developing single gene testing, which you had to be really good if you were suspecting someone had Phelan-McDermid and involvement of the SHANK3 gene. Most of those cases were picked up on whole exome sequencing, where we were looking at the coding parts of all the genes, and oh gosh, we found a mutation, or what we would prefer to call a pathogenic variant of the SHANK3 gene, which is causative, or at least in large part causative, for the features that we see in Phelan-McDermid syndrome.
That's what we found with Evie. We went through the microarray, nothing showed up, and then it took a while before we got proper diagnosis.
Right, and as you know from your own experience, getting through the morass of dealing with insurance companies in order to get the testing paid for, plus even finding a geneticist or someone else to order that testing.
So in the U.S., if you have a child with a disability, you need to get approval from the insurance company to get tested, to get a particular test?
I will say that first you have to get referred to someone who is going to order that testing, and that's usually going to be a clinical geneticist, like I am. That may entail quite a wait based on the number of geneticists that are seeing patients, and so that may take 3 months, 6 months, and I've heard 24 months. And if you're a parent with a child for whom you are desperately seeking a diagnosis, not that we may have a treatment for that diagnosis, but I think knowing is always better than not knowing.
I agree. And I'm not even sure is that actually a conversation? Is there anybody who says not knowing? Like, is there any argument for not knowing?
I would say the overwhelming majority of parents I've dealt with say, at least we know what we're up against now.
I remember having this conversation with my wife, and we had the conversation like it was a choice. Like, some people didn't want to know, but I've never met anyone who would not want to know. And I can't comprehend a parent saying, it doesn't make a difference. It's because
I think because of the availability of much better testing now and more accurate testing, I think we see that attitude less and less now. But let's face it, back when I started genetics in the 80s, it was a situation where we didn't have that many tests we could do. Many of our diagnoses were based on clinical evaluations and looking for sentinel features of a particular syndrome and making that diagnosis clinically. We had no way to prove that was the diagnosis. But if you fast forward 40 years, oh my gosh, our testing has become so incredible at allowing us to make diagnoses that we weren't even considering.
The diagnostic journey is one of the things that I think is really important. I know Cureshank and Geraldine are not just them, but like getting early childhood screening. Right now, nobody really knows what the numbers are, how many people have Phelan-McDermid syndrome. There's
numbers out there, but who knows how accurate they are.
Yeah, the numbers that are out there have basically been presented to be well underrepresented.
I think that's right.
Yeah. And because numbers, the higher the numbers, the more attention something gets, the more funding something can get, the more appetizing it is for private research companies to look at it.
I'll say, and university researchers.
Sure, yeah.
To investigate that particular syndrome.
Yeah. Trying to get the early diagnostic. Evie was 6 years old when we finally got the diagnosis of PMS.
When did you start looking for a diagnosis?
2 years old.
Right. So you had a 4-year journey.
Yeah. At 2 years, Evie was already behind her milestones. She was nonverbal. At 4, she started speaking a little bit. And then about 4.5, she got sick. She had a regression, which is kind of,
that can
common.
be typical.
Yeah. And she lost herself. She didn't have many words, but one of the things she would say is, "I want my daddy,"
which is worth $1 million.
Yeah. The last thing she ever said was, "I want my daddy." Her caregiver was taking her upstairs to bed, and she wanted me to put her to bed. And I was exhausted. Right. And as she was going up the stairs, that was the last thing. Yeah.
That's very difficult.
Yeah. But I'm pretty optimistic that whether she's 14 now almost, but whether she's 17, 25, or 45,
she still loves her daddy.
She was, yeah, there's no doubt about that. But we'll be able to have a conversation again.
Right. Does she use augmentative communication?
Not really. No, we're trying. It's very difficult. She has a severe ID, but she's sweet and she's lovely. She's got a sense of humor, and it's.
I wanted to get back to that insurance issue, which is a discussion to have when we're trying to get through that diagnostic journey. Because in the United States, insurance companies, I don't know whether I should say this, they control the money, therefore they have a significant input into how medicine is practiced. That's, in my mind, unfortunate, but different insurance companies may have on their list of approved tests chromosome analysis or a microarray or molecular testing such as whole exome sequencing, or they may not, or they may have a stepwise progression that they require you to go through in order to perform the testing. And these tests don't come back overnight. Many times families are traveling from a significant distance to get to the geneticist's office, so the appointments may be spread out. And all of that contributes to that diagnostic journey. The other big thing I think that contributes to the diagnostic journey is we need to train our physicians better. We need to make them more aware of Phelan-McDermid syndrome and other genetic syndromes And how do we diagnose those syndromes so we can get those answers as quickly as possible for the families and for that child? We can't offer any possibility of specific treatment without a specific diagnosis. And therefore, making that diagnosis is critically important in the scheme of treatment. And I'll say in developing new treatments.
Seems to be a catch-22 there in the sense of there's the newborn screening panel. And in the newborn screening panel, I think there are 50 things that they look for right now.
Right.
The latest one that was added was the SMA.
Right.
Because of a recent gene therapy available for it.
Right.
And they will not put anything on the panel unless there's a treatment for it.
Exactly. And that's always been one of the caveats of newborn screening. There must be a treatment. Although I will say in some states, Fragile X syndrome is being tested in newborns, and we don't have a specific treatment for that yet. And we've been working on that for years and years, which points out the difficulty in developing specific treatments for specific genetic disorders.
Well, again, it seems to be the catch-22. And like looking at Phelan-McDermid syndrome or Rett syndrome as well, the perfect example is these are two syndromes where it was the community that came together and raised funds and coalesced and created their foundations and so forth to be able to do the natural history studies and get all the information for the researchers to work on in order to get to where we are now, phase 1 gene therapy trials. So we couldn't have done that without the diagnoses. Do you know why they have that policy of unless there is a treatment available?
That was how it was established many, many years ago in newborn screening. And I think the reason for that was, one, the cost of the testing, which is negligible now for newborn screening, really. And two, why test for something when you don't have a treatment? Again, that was the old thought. I think the new thought now is if we could develop an efficient and cost-effective way to screen newborns, which I think will happen, I think we would do that. Now, that may mean parents may have to share some of the burden of that cost. But I could see in the future families being able to get a genetic testing panel for their newborn baby. The problem with any testing like that is we have a lot of unknowns in that testing. I talked about pathogenic variants, which are disease-causing. For every pathogenic variant, there are many benign variants, and there are many variants of uncertain or unknown significance. And at this point, we don't have a way to distinguish some of these variants and whether they will be associated with a clinical syndrome down the road in that child's life. And so you're balancing scaring, frightening families with this result when you don't know what it means. And as much as we try and tell a family, oh, don't go look this up on the internet, you know that as soon as they leave your office, they're going to the internet to, if they haven't already done that, to look that up. And I think we have to be considerate of the change in family dynamics that carrying the burden of a possible diagnosis can cause.
You mean a possible future diagnosis?
Right. Well, we don't do newborn screening for adult onset diseases.
Right.
And the reason for that is, do you want to live
In fear.
30, 40 years in fear of when is this going to happen?
Mm-hmm.
So there's always this ethical, legal, social implication balance going on
Mm-hmm.
as to what we should test for, when we should test for it.
Mm-hmm.
And again, how are you, from a policy standpoint, how are you going to pay?
Once we're at a certain point, I think what you were saying, once it gets cheap enough. And there's the balance of what's the cost of not testing.
Exactly. And we're talking about genetic disorders. And if you don't test for that genetic disorder, whatever the inheritance pattern may be, whether it's autosomal dominant, autosomal recessive, X-linked recessive, there may be a recurrence risk, especially if we're talking about recessive disorders. And if that is present, what are the risks to that family? And had they known their first child was affected with this particular genetic disorder, would that have altered their decisions
Yep.
as far as reproduction and how they wanted to approach that? So there is that huge benefit, I think, for families. But again, at the same time, the fear associated with a possible diagnosis. And you also have to realize that even within Phelan-McDermid syndrome, when you come to a meeting like this, you will see children who are mildly affected, and you will see children who are severely affected with Phelan-McDermid syndrome, and the developmental issues and seizures, and the list can go on and on.
Yep. For us, the way I was looking at it was, it took 4 years of us going to different doctors, neurologists, specialists, you name it, chasing.
Right.
And, in the Canadian system, yeah, that was paid for, but that's still inefficiencies in the system.
Right.
So the cost to whoever, there's a cost to it, whether it's insurance or us, or
Right.
there's a cost to it. And the cost, of chasing it down for 4 years. And these are hard costs. No, we're not talking about emotional costs.
I was going to say
Yeah.
psychological and
Yeah.
emotional costs to the family
Yeah.
are immeasurable in my book.
Me as well. But unfortunately, governments don't
Right.
necessarily.
Governments don't agree with
Yeah.
us.
And insurance companies don't agree with us. But so when I look at it, I try to look at it from a very pragmatic point of view, to, kind of the Vulcan taking the emotion out of it. But I mean, obviously the emotional aspect of it is, it really affects families incredibly. Just, yeah.
And it's difficult for us from the physician side.
Yeah.
When I want to do testing and I'm having to deal with an insurance company or funding from the government through Medicaid, and they deny the testing.
Medicaid is the government kind of insurance
For
policy?
children.
For children.
Right.
Okay.
Right. For children is Medicaid. Medicaid is a state program. It's funded with federal dollars and state dollars.
Okay.
But the Medicaid program in each state is a separate entity.
So are they run differently from state to state?
They are run differently, and they may enlist private companies to administer the Medicaid policy and reimbursement. So you may have several Medicaid providers in every state that are different in this state than this state, and your Medicaid does not follow you from, let's say, Texas to South Carolina.
If you
move,
okay,
you will have to reapply for Medicaid in that particular state in which you are now residing.
my understanding of the way the insurance companies run the healthcare system, there seems to be a lot of backdoor dealing. There seems to be between insurance companies and I have to remember this. There's basically a position which is supposed to be arm's length from the insurance company, which negotiates drug pricing.
Oh boy, you're getting into a complicated
It is
area,
complicated.
and I won't say I know all about that, but different hospitals may get paid different amounts for the same test or procedure, and I don't understand how that works. It
seems like there's just a general conflict of interest.
There's certainly a lack of transparency.
Right.
I'll call it that. And because of the lack of transparency, it makes understanding the system very difficult. And as a physician, if I order a test and it's denied, then I may have to do a written appeal. Then if that's denied, I may have to have a peer-to-peer review where I may be talking with someone on the phone that may not be qualified, as far as I'm concerned, to make decisions about genetic testing.
Right.
That's not their knowledge base. Just like I wouldn't be the person someone needed to talk to if they wanted to do orthopedic surgery, because that's not my area of expertise.
That must be frustrating.
It is very frustrating, and I have had a few arguments on the phone with people about that.
Lots of room for improvement.
Well, I think any medical system, I don't care which country we go to,
there's always
there's
lots.
always room for improvements.
Yeah.
And many times the policymakers at the funding agencies, whether that's private or government, don't have the expertise to be able to fully understand what patients and families are going through.
Mm-hmm.
It's not just a numbers game and dollars and cents. It is real people who are battling for their child's health and their own health. And sometimes I think the policymakers don't have a good feel for that.
Yeah, I think that's fair to say. For me, I try not to get caught in that trap of what system is better.
No, I think they're from the physician side. I pretty much think they're all not that good.
Right.
That they could all be better.
Yeah.
And I think it's up to the people wherever they live to vote for people who are going to change those policies. But again, so much of it is done behind closed doors. It's like making laws. People talked about two things you don't want to know how they're made: sausage and laws. So I think we have to be careful that way. And many times, I'm not sure the general public would have the stomach for how these policies come about.
When I look at, I kind of use an analogy when I look at insurance for healthcare in particular. My personal feeling is that anything with healthcare should have zero conflict of interest.
I agree.
And the system is regardless of which system, there are many conflicts of interest. But it seems to me like the health insurance industry as a whole, I think the U.S. is no. I forget that. I think it's like $2 trillion a year or something like that. The U.S., the health insurance industry.
All I know is it's a lot of money.
And I thought to myself, okay, here's an industry that's employing a lot of kind of white collar administrators, CEOs. That's pretty much it. And everybody that, they kind of, and if you just took all that layer out of all the money that they're siphoning out of the system would just run directly and efficiently.
Well,
and
but a lot of those people, you've got to have some administrators, and I'm not going to say that the government administrators are any better than the private administrators.
Right.
And I don't know how you build that system, because there is no perfect healthcare system. I don't think we as humans have figured out how to build the perfect healthcare system.
Yeah, it's
there's got to be some type of cost control, because there is not unlimited money available.
Yeah.
And because of that, there are going to have to be administrators who are somebody developing the policy so that the best care for the most people can be provided.
Absolutely.
And it's never going to be perfect.
No, I mean, there are certainly places on the planet where they seem to have a better grasp on it than other places. But it's definitely
as we talked about, somebody's always going to be paying for that.
Oh yeah,
Whether that
comes
is paying for private insurance or paying taxes to pay for Medicaid, Medicare, or whatever your system is called wherever you live. And I would say we in the United States don't like to pay taxes.
You just pay it in a different way.
That's right. We pay it in a different way.
Yeah.
So and politicians are elected based on lowering taxes.
Yeah.
And I'm not going to sit here and say I enjoy paying that money, but I think we have to realize that for the good of the population, there are certain things that we're going to have to help pay for.
Yeah, it's a shift in perspective and priority of the population.
Yes, it is.
Yeah,
it comes in waves or in cycles as far as how willing people are to pay for different things.
Yeah.
I think our leadership, both at a local and state and national level, influences that and the rhetoric that leads to how policy develops.
I imagine a world in where the top ministry of the government is the health ministry, and that all decisions made for finance and economics and geopolitics and all these should be viewed upon through the lens of healthcare. What makes our population the healthiest? Because a healthy population is a happy I think is happier and I think more successful.
Yeah. And is able to better pay those taxes, and you have more people contributing. But you're an idealist, obviously.
That I am. Absolutely.
We were just talking about being pragmatic.
I think everything's possible. given enough time for humans to make their mistakes, and hopefully learn from those mistakes. But then there are things that I want to get into. I was curious about. You're retired from.
I'm not seeing patients anymore. I give a talk here and there every now and then, but that is just something I want to do. No, I retired from seeing patients about 18 months ago.
So it's a really, interesting time in terms of, there's gene therapy, which we'll get into, but I was thinking about, how AI is going to change medicine. You were talking about getting results of genes, of variants of unknown concern, or so something that AI would be good at is
right, and those programs are being developed to model the effect of a change in a gene on the protein it encodes, and whether that is going to affect the function of that protein. That's coming. Even in clinical genetics, for years we have had programs out there that in which you could download, with the family's permission, a picture of the individual and put in a few key characteristics that they have, not of their facial features, although you could put those in, but intellectual disability, seizures, things like that. And the program would be able to use that facial recognition based on what it had learned from seeing other people with that particular syndrome, and using that information to help suggest a list of diagnoses that might fit that patient. Now, that's still valuable. It's not quite as necessary for us to have that type of help now that we have so much testing available that is able to pinpoint diagnoses. So we've had those things around for a long time, and they're getting better, and will continue to get better. And we will have many tools in our armamentarium to make diagnoses earlier. The other thing you have to remember when you're doing facial recognition for a syndrome, whether it's the computer doing or whether it's my brain doing it, you recognize, one, what you've seen, and the more times you've seen it, the better you recognize it. And two, there's a wide variance, even within the same syndrome, of the features of the face, the hands, the feet that we might see. And that is what indeed makes a clinical diagnosis difficult, whether it's the human making the diagnosis or the computer making the diagnosis. There can be so much variance there that it can be very difficult to do that. But it will get better and better, just like our ability to do genetic testing has gotten better, just like our ability to evaluate someone's heart has gotten better. Things improve. We go from x-rays to CT scans to MRIs, and our ability to evaluate diagnosis improves step by step.
So, speaking of improvements in terms of gene therapy, so seems like we're at the very beginning.
We are,
which is a wonderful place to be because it's the beginning. Before the beginning, there was none.
There was only night.
Yeah. So in 2018, when I was at the first conference, I think we talked about this before, that I brought up CRISPR and gene therapy, and everyone looked at me like a deer in headlights, thinking, We're decades away, and that was 6 years ago. So Rett syndrome already are in their phase 1-2 trials of two different gene therapies. In beginning of 2025, I believe Jaguar Gene Therapy is going to be starting their gene therapy trial for Phelan-McDermid syndrome.
Right. For SHANK3.
For SHANK3. By adding a little mini gene, like a portion of the SHANK3, because I guess it's too large to fit in the...
That's right. And there are a lot of difficult scientific issues involved in gene therapy. The first thing to remember about gene therapy is it's like real estate. Location is everything. So you've got to... It's not difficult to make a gene these days, or a portion of a gene. We can sequence those. We can replicate that. The problem becomes, how do you get that gene to the location in the body where it needs to be to cause the desired effect? If we're talking about Phelan-McDermid syndrome or Rett syndrome, the main place we want to be is in the brain, because the overriding issue that we're facing is severe developmental issues that may also be associated, especially in Rett syndrome, with developmental regression. Things are getting worse and worse. So we have to try to treat early. We have to be able to get the gene to the right location. We have to get that gene incorporated so that it will become, let's call it, active, and be able to produce the protein that is needed to fulfill the function of what that person is missing. Our other problem is that our bodies are wonderfully made, and without our innate and acquired immune systems, we would all die very early in life, because we are made to fight off foreign invaders. And many times our body may see trying to put a virus in, carrying a gene, a human gene, they may see that as foreign material and attack that and thwart our best efforts to get that gene incorporated into the cells that we need to be treating to get the best effect. So we're working against our own body. We also have to design things that, in the case of neurological treatments, we have to design things that will get past the blood-brain barrier, which is this mythical barrier, and only small substances, genes, or viruses will pass through that. We are learning how to use different viruses that target different organs more selectively to carry the genes to the particular part of the body, the system we want to treat. However, again, we're limited by the size of the material that the gene can carry, that the virus can carry. So you can't put a gene this big in there. We can take a part of that gene and put it in there and still be able to transfect the cells and get that gene into the cells. But boy, it's tough. There are a lot of challenges with that. So if you need to get across that blood-brain barrier, either you've got to come up with a better transport system to somehow open the gates, let's call it, to allow things to get from the blood into the brain tissue. Or your other option is to go around that and to inject that directly into the brain tissue itself and hope that you get enough spread in the brain cells that you can create an adequate effect from your gene therapy.
The Jaguar therapy, they're doing ICV.
Right.
So that's a direct injection to the brain. So that will.
Right.
So have you heard of Capsida? Capsida is a company that's working on a gene therapy for STXBP1.
Okay.
It's a seizure disorder.
I know that one.
And they're starting their gene therapy trial in 2025, as they call it IV gene therapy. And they basically put the vectors in a little capsid and it's through IV. And they found in non-human primates from their material, they've been able to get about 70% kind of coverage in the brain.
Right. That's awesome.
Yeah, through IV.
That would be amazing.
A big game changer, yeah.
Yes. I mean, we've tried a lot of things to get around that blood-brain barrier. Different tagging, the virus that carries the gene with an antigen that is met by a receptor at the blood-brain barrier and recognizes that and then helps transport it across. There are a lot of ways to approach the problem. Again, it gets back to how incredibly wonderfully we are made and designed and evolved, and it's difficult. Again, the same things that keep us alive many times thwart the therapy that would make us better.
I want to ask you about the diagnosis of autism. A diagnosis of autism on its own doesn't really do much aside for in Canada. It opens up doors to getting funding.
You can get services and funding based on the diagnosis of autism, especially in the school system.
Yeah,
it helps your child get services. Does it tell you anything about the cause or etiology? It does not. Autism to me is a description of the neurobehavioral features we're seeing in that individual. It says nothing about the cause, and there are thousands of causes literally for autism. And Phelan-McDermid syndrome is one of those associated autism. We see SHANK3 variants. We see kids with developmental issues, intellectual disability, and autism combined. And in that group, we know there are going to be a certain percentage of those children or adults who are going to have Phelan-McDermid syndrome. I don't think we yet have an accurate number for whether that's 0.5, 1.5, 2%. I don't think we have a good handle on that yet, because all the children who have and adults who have autism have not been tested. So how do you know those numbers? We were talking about newborn screening. If we did newborn screening on every child, a thorough genetic newborn screening, I think then we might be able to get a much more accurate diagnosis and representation of frequency and incidence in the population. But again, that's expensive. And in the United States, no one is forced to have newborn screening. That is an optional test. We recommend it. We discuss it with the parents of every baby born, but they can opt out of newborn screening.
Is that kind of a general thing that insurance does cover, newborn screening?
Yes, yes. And that's built, it's almost built into the cost of providing the health care and having a baby, and the state, typically a state laboratory is doing the testing.
Oh, I see.
And so that state laboratory is funded by that state government, and the cost for the testing is absorbed by the state, and they also help absorb the cost of obtaining the specimens for the testing, which is usually a heel stick and putting a little blood on circles and sending that off to the state lab.
I'd like to thank Dr. Rogers for taking the time to share his story with Generation Hope. This interview was recorded at the Phelan-McDermid Family Conference in 2024, and a lot of developments have happened since. The Jaguar gene therapy trial has now dosed 4 kids with his JAG201 ICV gene therapy with no reported adverse effects. The PYC Therapeutics ASO is also on schedule for a first-in-human trial for the summer of 2026. If conversations like this help you understand what's coming or give you hope for families like mine, please subscribe, like, and share this video so more families, clinicians, and researchers can find it. I'm Ron Clayman. Thank you for watching Generation Hope. And until next time, stay hopeful.